and discuss methods for implementing pressure injury prevention for inpatient bariatric patients. According to the National Pressure Ulcer Advisory Panel, or NPUAP, a pressure injury, formerly known as a pressure ulcer, is a localized area of damage to the skin and underlying soft tissue, usually over a bony prominence or related to a medical or other device. The injury can present as intact skin or an open ulcer and may be painful. The injury occurs as a result of intense and/or prolonged pressure or pressure in combination with shear. The tolerance of soft tissue for pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue. Now let's briefly explore the epidemiology of pressure injury, first looking at occurrence and significance of the problem. Unfortunately, 2.5 million acute care patients in the United States are affected annually by pressure-related skin injuries. Furthermore, the development of hospital-acquired stage 3 and stage 4 pressure injuries are considered an adverse event by the Centers for Medicare and Medicaid Services, or CMS. On this slide, I've listed other significant issues related to pressure injury to the skin. The first bullet speaks to the financial aspects. One single pressure injury may take months to heal and substantially impact a patient's quality of life, as well as place a significant burden not only on their ability to financially absorb the medical costs associated with treatment of the wound, but place an additional strain on expenditures incurred by the hospital to address this unplanned patient event. In fact, BREM 2010 found that a hospital-acquired stage 4 pressure injury was associated with an overall cost of $129,248 for a single admission. Bullet 2 speaks to pressure injuries as they affect a patient's quality of life. According to Yap et al. 2018, pressure injuries are associated with many complications, including amputations and septic infections, and with overall deterioration in prognosis, compromising both a patient's health status and, again, their quality of life. Bullet 3 speaks to an alarming statistic. 60,000 patients in the United States, in the acute care setting that is, die each year from complications related to pressure injuries to the skin. Therefore, identifying those patients at risk is the first step in preventing pressure injuries to the skin in the hospital setting. Now we are going to take a look at a brief review of the etiology and pathophysiology of pressure injury to the skin. So let's start out by asking the question, what makes a person vulnerable to pressure injury to the skin? Well, there's a multitude of intrinsic and extrinsic factors that can contribute to pressure injury formation and progression, and the majority of them are listed on this graphical depiction before you. For instance, you see poor nutrition, neuropathy, age, skin changes, mental status, incontinence, even chronic illness can make a person susceptible to pressure injury development. A lot of times we tend to forget about chronic illness as a risk factor, but certainly diseases like arterial sclerosis, diabetes, and obstructive pulmonary disease can increase one's susceptibility to pressure injury development. As we have discussed, there are many factors that can contribute to the development of pressure injuries, but the final common pathway to ulceration is tissue ischemia. The tissues are capable of sustaining pressure on the arterial side of around 30 to 32 millimeters mercury pressure for only a short period of time. But when pressure increases even slightly above this capillary filling pressure, it causes microcirculatory occlusion, and this in turn initiates a downward spiral toward ischemia, tissue death, and ulceration. Pressure injuries can develop when a large amount of pressure is applied to an area of skin over a short period, and in turn, they can also occur when less pressure is applied over a longer period. The tissue distortion occurs either because the soft tissues are compressed and/or sheared between the skeleton and a support, such as a bed or chair when the person is sitting or lying, or because something is pressing into the body, such as a shoe, a prosthesis, a surgical appliance, or even the elastic from the patient's clothing. Simply put, when there is ischemia to this organ, the skin, you can almost consider it to be a skin attack in a sense, a very lesser sense, comparable to the ischemia that occurs with a heart attack. I think this is a helpful slide that reminds us of the anatomical areas of concern in relation to pressure injury development when a patient is lying or sitting. You know, it's important to pay particular attention to those patients that tend to sit up in wheelchairs for extended periods of time. You might want to, pay particular attention to the back of the shoulder blades, the elbows, the back of the knees, as well as the back of the heels when resting against the footrest devices of the wheelchair. People with normal mobility do not usually develop pressure injuries, as their body automatically makes hundreds of regular movements that prevent pressure from building up on any part of their body. Think of it when you're sleeping at night. You unconsciously reposition yourself thousands of times during the night to prevent pressure to any area of your skin. But unfortunately, when patients do have mobility concerns, they are at increased risk for pressure injury development. I think this is another helpful slide that reminds us how shear can also contribute to skin injury. Shear forces are unaligned forces pushing one part of a body in one direction and another part of the body in the opposite direction. Shear stress causes an object to deform from its original shape. Thinking about that definition, let's look at this photo of this coccyx wound. Imagine that perhaps at one time this patient was repositioned up in bed, and what occurred was the skin stretched up toward the head of the bed when the patient was moved upward, but the remaining weight of the coccyx bone stayed stationary to the bed itself, to the mattress, thus resulting in tearing and shearing of the skin area. So this is a good reminder that a patient should be lifted up in bed with a draw sheet or other type of pad or apparatus in order to prevent the shearing forces that would result in damage of this kind. Again, with this slide emphasizing how shearing forces can contribute to skin injury in vulnerable areas of the body as well as in vulnerable patients, usually related to incorrect repositioning in a bed or chair. Friction is another risk factor for skin injury formation. According to the National Pressure Ulcer Advisory Panel, friction is the rubbing of one body against another, or the force that resists relative motion between two bodies in contact and/or material elements sliding against each other. There are two types of dry friction, static and dynamic. Static friction is the force that prevents a person from sliding down the bed when the head of the bed is raised. The amount of friction that exists at the skin surface depends on the skin's surface properties, for instance, hydration level, and what is in contact with it, for instance, bed linens, clothing, etc., and the magnitude of pressure or force. Dynamic friction exists when a person is sliding in bed or when their foot rubs against the inside of a shoe and might result in the formation of blisters, abrasions, skin tears, and acute skin trauma, and may be misdiagnosed as a pressure injury. As a brief review, let's go over the pressure injury classification system. Let's look at deep tissue pressure injury first. Remember, deep tissue pressure injury was formerly known as suspected deep tissue injury. In deep tissue pressure injury, there is intact or non-intact skin with localized area or areas of persistent non-blanchable deep red, maroon, or purple discoloration or epidermal separation revealing a dark wound bed or blood-filled blister. Discoloration may appear differently in darker pigmented skin. This injury results from intense and/or prolonged pressure and shear forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of tissue injury or may eventually resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or other underlying structures are visible, this indicates a full-thickness pressure injury that could be classified as unstageable, stage 3, or stage 4. In a stage 1 pressure injury, there is intact skin with a localized area of non-blanchable erythema, which may appear differently in darkly pigmented skin. Presence of blanchable erythema or changes in skin sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. Remember, those types of changes may indicate a deep tissue pressure injury. In a stage 2 pressure injury, there is partial thickness skin loss with exposed dermis. The wound bed is viable and may be red or pink, moist, and may also present as an intact or ruptured serum-filled blister, not a blood-filled blister. Adipose tissue is not visible and deeper tissues are not visible. Granulation tissue, slough, and eschar are not present. This stage should not be used to describe moisture-associated skin damage, including incontinence-associated dermatitis, intertriginous dermatitis, medical adhesive-related skin injury, or traumatic wounds such as skin tears, burns, or abrasions. On the other hand, a stage 3 pressure injury involves full thickness, loss of skin, in which adipose tissue is visible in the ulcer, as well as granulation tissue and epipoly or rolled wound edges are often present as well. Fascia, muscle, tendon, ligament, cartilage, and/or bone are not exposed. A stage 4 pressure injury is full thickness skin and tissue loss with exposed or directly palpable fascia, muscle, tendon, ligament, cartilage, and/or bone in the ulcer. Slough and/or eschar may be visible. Epipoly or rolled edges, undermining, and/or tunneling often occur. Depth varies by anatomical location. If slough or eschar obscures the extent of tissue loss, this is an unstageable pressure injury. An unstageable pressure injury is a full-thickness skin and tissue loss of a pressure injury in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured by slough or eschar. If slough or eschar is removed, a stage 3 or stage 4 pressure injury will be revealed. Please note if the eschar is stable, meaning it is dry, adherent, intact, without signs and symptoms of erythema or fluctuance on a heel or another ischemic limb, it should not be softened or removed. We are now going to switch gears in this presentation and devote the remaining portion to the risk factors involved as well as the care recommended for the bariatric inpatient in preventing pressure injury to the skin. Obesity is becoming an epidemic in our society. At the core of the problem lay an imbalance between calories consumed and calories expended. But according to Ramul et al. 2017, quality, not quantity, is the driving force behind complex hormonal and neurological pathways that control hunger, satiety, and other mechanisms contributing to weight maintenance. Although interesting concepts, it is out of the scope of this presentation to further examine the topic of weight management, and I strongly recommend that you investigate further evidence-based resources to continue to explore this subject more thoughtfully and thoroughly in the future. The United States contains one of the highest percentage of obese people in the world. To gain a clearer understanding of the impact of obesity and the risk for pressure injury to the skin, let's first examine the definition of some key terms as they relate to body weight composition. First, the common acronym BMI stands for Body Mass Index and is a measure of body fat based on an individual's weight in relation to their height. Therefore, before you on the screen, you'll see the common definitions of BMI. For instance, a BMI equal to or under 18.5 is considered underweight. A BMI between 18.5 and 24.9 is considered normal weight. A BMI between 25 and 29.9 is considered overweight. And a BMI equal to or above 30 is considered obese. I give you these numbers and these definitions, but please keep in mind that the use of body mass index in determining a patient's healthy weight is actually becoming more controversial in current literature. According to Hosworth and Gallagher 2017, a higher BMI can indicate a higher level of body adiposity. However, BMI should only be used as a screening tool, not a diagnostic tool, because a higher BMI also occurs with increased muscle mass, ascites, or pregnancy. The term bariatric is often used to describe a medical area specializing in treating obese patients, and the term bariatric may be also used to describe obese patients. According to Bites 2014, bariatric is a word derived from the Greek word baros, which means weight. A bariatric patient is of greater size, usually with a BMI greater than 30. According to the CDC, the prevalence of obesity is around 39.8% and affected 93.3 million U.S. adults as reported between 2015 and 2016. To help you better understand the gravity of this situation, an interesting article by Cusi 2017 stated that the average woman in the United States today weighs about 168 pounds, or roughly the same as an average man in 1960. In addition, Cusi went on to state that men had gained an average of 30 pounds since JFK's inauguration in 1961. In addition, on the America's Health Rankings, a United Health Foundation website, 26.7% of women between the ages of 18 and 44 are currently considered obese. However, according to the National Institute of Diabetes and Digestive and Kidney Diseases, among all age groups, about 40% of women are obese, and extreme obesity, a BMI greater than 40, is higher in women as compared to men. Also, the CDC reports that roughly 34.5% of men aged 20 and over are obese. Now that we have explored some interesting statistics concerning obesity, let's next examine some key risk factors for pressure injury development due to obesity. According to Halsworth and Gallagher 2017, the ability of morbidly obese patients to effectively reposition themselves or alleviate the pressure on the skin and underlying tissues is frequently compromised and can lead to injury of the skin and underlying tissue. In addition, unique pressure injuries can occur related to medical device-related pressure injuries caused by tubes or catheters burrowed deep within skin folds. Medical device-related pressure ulcers are defined as pressure injuries associated with the use of devices applied for diagnostic or therapeutic purposes, wherein the pressure injury that develops has the same configuration as the device. Furthermore, side rails or armrests that are not accommodating to a larger patient may also contribute to pressure injury. In fact, if a bed is not wide enough to accommodate a bariatric patient to turn to their side, this may also hinder pressure relief and pose a risk for pressure injury in this population group. All patients are at risk for medical device-related pressure injuries, and on this screen before you, I have included some various real-life photos of patients that have sustained injury from some of these medical device apparatuses that we often encounter in our practice. If you look toward your upper left-hand corner, this first photo here, you can see that this patient has sustained quite a bit of indentation from tubing to their back. Looks like likely the culprit is either the feeding tube or the EKG wires, or perhaps both. The middle photo here is an infant. It appears that it has endured pressure injury from their trach site area. This adult looks like the straps of the trach have caused significant pressure to the neck. Often in the intensive care unit, you'll see the endotracheal tubes that could potentially cause pressure to the mouth and lip areas, as you see in this photo here. This patient looks like they've sustained quite a bit of pressure to the ear area, likely from an O2 mask strap. And you'll often see that as well to the back of the ear with O2 cannula tubing. And this last picture here on your bottom right appears that there is pressure injuries within the skin folds from the Foley catheter area here. So these are actual real-life photos and very similar to the types of medical device related injuries that I have seen in my practice as well. We're going to switch gears here from medical devices and speak momentarily about interface pressure, because I would like for you to have a better understanding of this term, because you often see it utilized in the literature when researchers are discussing the pathophysiology behind pressure injury development. So I might just get slightly technical here, but I hope that this perhaps can give you a good foundation of the physiology behind why a pressure injury develops in certain anatomical locations. So when a person is lying or sitting, pressure is transferred from the external surface through the layers of the skin toward the underlying bone, as you see in this graphical depiction here on this slide before you. According to Hugendorn, Wernalda, Koopman, and Reitman, 2017, interface pressure results mostly in a decrease in skin blood flow, or blood perfusion, compared to baseline levels during the load application. The decrease in skin blood flow is related to the magnitude of pressure and seems related to the location of load application. Locations with less tissue thickness show a faster decrease in skin blood flow. So let's just momentarily digest that definition for just a second here and really think about how we can apply this to our clinical practice. So if you think about the areas of the body that perhaps have less tissue density, one that frequently comes to mind is the heels, the back of the heel area, compared perhaps, let's compare it with perhaps the buttock area that has a more dense tissue thickness. And if you think about our immobile patients and why you often see pressure injury to the heels versus perhaps to, again, the buttock area, it is because of the lesser tissue density, and when pressure is applied to that area of the heel, it will have a faster decrease in perfusion or skin blood flow. And the heels are often the number 2 anatomical area of skin injury, pressure injury, with number 1 being the coccyx sacral area in the hospital setting. In fact, according to Fletcher et al., 2017, the heels are thought to be particularly at risk of acquiring deep tissue injury because the underlying bony prominence, the calcaneus, has a small radius of curvature, i.e. is relatively pointed, and the layer of tissue overlying the bone is relatively thin. This means that the intensity of a mechanical load applied to the heel can be high. Although interface pressure was an important concept to bring up, I think another very important topic to cover, at least briefly, is the patient's nutritional status and how nutritional compromise can increase one's risk for pressure injury. In addition, there are many misnomers out there in regards to malnutrition and the obesity state, but you can see malnutrition in obese patients. Malnutrition is really an all-inclusive term that represents all manifestations of poor nutrition, and patients with obesity can be prone to deficiencies of micronutrients such as zinc, iron, and vitamins A, C, D, and E. These are the nutrients that are crucial for proper wound healing. In addition, there are other studies that suggest that obesity can be linked to low-grade chronic inflammation that increases one's risk for metabolic and cardiovascular disease and also disrupts protective immunity. Lastly, there is a lot of research that suggests that individuals that are obese have an increased risk of infection to the skin and to the respiratory tract, as well as surgical site infections. And these have been consistently reported more in the obese population as compared to the normal weight population. While we're on the subject of obesity's link to cardiovascular disease, according to Niermacher et al. 2017, endothelial dysfunction is a predisposing factor for atherosclerosis and other cardiovascular diseases. And at the same time, endothelial dysfunction is associated to obesity. The endothelium lines the interior surface of blood vessels, and within this figure that is shown on this slide before you, an overview of the molecular underpinnings associated with endothelial dysfunction, atherosclerosis, and obesity are displayed. As depicted here in this slide, obesity is associated with high levels of cholesterol and triglycerides in adipose tissue, which activates an inflammatory response, leading to a cascade of vascular inflammation and plaque formation in the vessels. This can predispose individuals to cardiovascular disease and, in turn, can exacerbate conditions favorable for peripheral arterial disease, which may increase vulnerability to lower extremity pressure injury formation and/or delayed healing. Other factors that can increase one's susceptibility to pressure injury to the skin, and that is especially seen in the obese population group, is maceration and intertriginous areas to the skin. Moisture-associated skin damage is inflammation and erosion of the skin caused by prolonged exposure to various sources of moisture and its contents, including urine, stool, perspiration, wound exudate, mucus, or saliva. In addition, prolonged exposure to moisture damages the outermost layer of the epidermis and makes it more susceptible to friction or shear damage and subsequently to infection. Deep and hidden skin folds in obese patients are susceptible to accumulated and hidden moisture areas that can potentiate skin fragility and damage from potential sources of pressure caused from external devices, or in some cases even by the pressure caused by a heavy overhanging skin fold. The term intertrigo is often used to describe skin folds, dermatitis, or rashes between skin folds. Another key factor that can predispose an obese patient to pressure injury risk is their accompanying high risk for comorbidities. There are many research articles that provide evidence to support the increased risk of comorbidities with obesity and morbid obesity. As stated earlier, atherosclerosis caused by elevated cholesterol and triglycerides can lead to cardiovascular disease. In addition, it is well documented that obesity can be linked to type 2 diabetes, obstructive sleep apnea, venous insufficiency, non-alcoholic fatty liver disease, and other chronic disease states. Compounding this issue is the realization that individuals with chronic illness are more likely to be hospitalized, and this alone may increase the chance of developing a pressure injury to the skin in their lifetime. Now that we have discussed and examined the key risk factors that can lead to pressure injury in the obese and morbidly obese population group, let's use the remaining portion of this presentation to focus on pressure injury prevention for bariatric inpatients. As the old saying goes, an ounce of prevention is worth a pound of cure. Preventing pressure injuries of the skin from occurring in the first place is key when working with any inpatient. However, there are some unique considerations that you may want to be especially aware of and attentive to when working with bariatric inpatients. Prevention is always a greater intervention to initiate than reacting to a problem that has already occurred, and really resonates with another not as old saying, work smart, not hard. When considering the prevention of pressure injuries in the bariatric population group, one of the key components to address is the unique immobility and biomechanical challenges of this segment of the population. One important fundamental and initial areas to evaluate is the proper sizing of equipment. This ensures both the patient and the caregiver's safety and will ensure as well that the patient can comfortably maneuver and reposition themselves in this bed or this wheelchair that is selected for their care. According to Morello 2017, the width measurement of a body's widest point should also be considered in support surface and wheelchair or other bariatric equipment selection. Standard hospital bed mattresses are only about 32 to 36 inches wide. Therefore, one must consider the patient's width, and when they're lying in a standard bed that's 36 inches wide, will the patient be able to maneuver themselves and turn from side to side? As you can see from this graphical depiction, the patient on the left-hand side that's drawn can only do a one-turn diameter maneuvering to their side, whereas the patient on the right-hand side can turn to both sides easily. Therefore, it is recommended that if a patient has a BMI greater than 35, then they should have sufficient space to maneuver laterally, which would likely be a wider accommodating bed for those purposes. While I'm on the subject of proper sizing of equipment, I want to emphasize how imperative it is that bariatric inpatients be placed in the correct size bed from the time of admission, and that might start even prior to admission if a planned elective procedure is scheduled, or it could start in the ER or perhaps in the surgery suite. Because once a bariatric patient is placed in a standard-sized hospital bed, actually we may increase the risk for injury later on when attempting to transfer them later on to a bariatric-sized hospital bed. And on this screen we talk about microclimate management, and a lot of these airflow beds have this component of technology built into their mattress system. And what that is, the microclimate is managing the patient's temperature and moisture, so it's regulating that constantly to decrease any potential breakdown between their skin folds or between their individual support surface interface. So it's constantly regulating the temperature and moisture components of the bed, and keeping in mind that we're also repositioning our patients as normal in these beds. That also helps facilitate the cooling and moisture dissipation from the skin with this type of microclimate technology. And it's also very vital that you understand what linens, chucks, or underpad to use with these specific beds, these airflow mattresses. You definitely want breathable, non-plastic incontinence pads because they do not interfere with the airflow mechanism or this microclimate technology of the mattress. And here's just one more slide on the subject of proper sizing of equipment for the bariatric patient. A typical bariatric sized wheelchair, and you just don't want to think about the wheelchair, also think about furniture in the room. Do you have bariatric sized furniture for the patient to sit in? Perhaps if they want to get up out of bed, you do not have a bariatric sized wheelchair available. Do you have bariatric sized chairs for the patient to sit in comfortably when they're out of the bed? So that's something to consider not only for your inpatients but in your outpatient clinics as well. Another key intervention in addressing pressure injury prevention is monitoring any medical devices that can lead to pressure injury of the skin, especially in your bariatric population, but all patients are at risk for pressure injury due to medical devices. You definitely want to follow some of these key bullet points here on the screen, such as having the correct sized medical device for the individual patient, perhaps cushioning underneath the medical device in areas of high risk with the dressing, inspecting the skin in contact with the device at least daily unless medically contraindicated, avoiding placement of devices over prior or existing pressure injury, educating the staff on correct use of the devices as well as the patient and the caregiver. Be aware of edema under some devices that can lead to potential skin injury, and confirm that devices are not placed directly under an individual who is bedridden or immobile. And on that note, remember that non-medical devices can also cause pressure. So sometimes patients can get things lost in their bed and unknowingly lie on something that could lead to pressure injury to the skin, such as a call light button, eyeglasses, writing pen, cell phone, etc. So be sure that you're monitoring that as well to ensure that there's nothing that the patient's lying on unknowingly. And on that note of preventing medical device injury, on this slide you'll see various photos of different patient scenarios where prophylactic dressings were utilized under medical devices to protect the skin from causing injury. And you can just follow the red arrows to get an indication of how these dressings were utilized. Just remember that it's important not to create more pressure by placing too thick of a dressing beneath an already tight device as a preventative measure. But otherwise, in these various photos, you can see how different options were used to prevent injury from the device. Addressing the skin integrity is very essential. Obviously, you want to assess skin at least each shift, but likely more often in this population group, given the fact that they're at high risk for skin breakdown, especially looking under skin folds. For instance, if you look underneath the breast, sometimes you'll see areas of irritation, as well as looking under the abdominal pannus and other large areas of skin folds. But don't just look for areas of increased problems with moisture, but also you might want to consider areas that could be too dry. For instance, in this photo here, you can see that the bottom of the foot is very calloused and has contributed likely to the splitting of this area or this wound on the plantar aspect of this foot. So inspecting the skin, looking for redness, increased warmth, coolness, discoloration, what the moisture's like, and any other breakdowns is essential with your skin assessment. In obese patients, the higher percentage of adipose tissue can also lead to increased perspiration and altered skin barrier function, as can incontinence and any source of excess moisture to the skin. I did include some key pearls related to incontinence to keep in mind, such as protecting your patient's skin, keeping it dry but supple, meaning soft, not overly dry, cleansing soiled areas as soon as possible, pat dry, do not rub or forcibly remove any prior barrier if still visible from the skin. Just target the areas that are soiled and clean those areas and reapply the barrier as needed. You might need to use moisture barrier products as well to repel moisture and irritants. Cleaning after soilage with pH balanced skin cleanser is the preference. Also consider using a skin moisturizer to hydrate dry skin and reduce any skin breakage from cracks or fissures like we saw in that prior photo of the foot. Avoid adult briefs when possible. They're a source of moisture retention and concealment. And as far as intertrigo is concerned, you'll see on this slide here this photo of an intertriginous area underneath the skin fold. You too want to keep these skin folds clean and dry. Prevent skin-to-skin contact. There are many wicking products on the market that are commercially made. One of them is Interdry AG, which is this one here to your left. That's a product that's made by Coloplast that's commercially made as a fabric to place in between skin folds to help with wicking excess moisture. And also this particular product has some silver impregnated in the fabric to prophylactically address the chances perhaps of infection, because a lot of times with intertrigo, these areas are aggravated by heat, maceration, and friction or chafing that can lead to inflammatory dermatitis, sometimes even fungal or bacterial infections. So these products are available, but there's other products that could potentially be used as well, but you certainly want to avoid skin-to-skin contact if possible in these larger skin folds. Addressing nutrition from the get-go is important in preventing pressure injury to the skin. You want your dietitian involved in your high-risk patients to monitor these patients, to screen these patients, especially since obese patients can be at risk for protein energy malnutrition. As I conclude this presentation, I would like to leave you with one final thought or word about patient dignity and respect. Often as healthcare providers, we become somewhat desensitized to some of the terminology that we use in everyday practice. So when you work with obese and or morbidly obese patients moving forward, reconsider some of the terminology that you use. For instance, when you say big or large, you might want to perhaps reframe that to maybe a word like another or better or more comfortable bed or chair that you will get for this specific patient population. So I'd like to challenge you to think through that moving forward. And I hope that this entire presentation was helpful for you and that it will aid in improving your practice with preventing pressure injuries, especially in the bariatric inpatient population moving forward.